Good morning, good afternoon, and good evening, everyone. Welcome to our webinar today to launch the Thematic Brief, Nurturing Care for Every Newborn, ensuring that every newborn survives and thrives. This webinar is organized by the World Health Organization and UNICEF in collaboration with the Network for Improving Quality of Care for Maternal, Newborn and Child Health and the Quality of Care subgroup of the Child Health Task Force and ECTAN, the Early Childhood Development Action Network. This webinar is part of a series on transforming care for small and sick newborns. And today we're delighted to launch the Thematic Brief for Nurturing Care. The brief will set out what happens during early childhood that lays down the foundation for our whole lifetime. Evidence has demonstrated clearly that the first hours, days, weeks after birth, the newborn period, are precious for child survival, for health and lifelong development. And this is particularly true for newborns that are born small or sick or who become sick shortly after birth. So we have the knowledge and tools to ensure nurturing care for every newborn so that they can survive and thrive and meet their full potential. And today's webinar aims to share that learning. So we have 4 parts to today's session. In part 1, what is nurturing care for every newborn? We will have presentations on the technical brief. In part 2, creating the nurturing care environment for newborns, the country experiences, we would hear from 5 countries of efforts that have been getting great rewards in country. Then we will turn to questions and answers. And in this part, we really want to hear from you. So please type your questions into the chat box throughout the session. And in this section, part 3, those questions will be posed to all the speakers today. In part 4, we're going to hear reflections from partners. And we will close today with some closing remarks from WHO and from UNICEF. So for part 1, and just before I introduce part 1, I must note that we will be sharing the recording from today of the presentations and the thematic brief. They will be on our websites, and there's a slide at the end that will show you exactly where to go. We will also email all participants with that information. So part 1, what is nurturing care for every newborn? To introduce the thematic brief, it's Natalie Chapak and Bernadette Delman from the World Health Organization to jointly lead this work. And then we will hear about infant and family-centered developmental care. We'll hear the explanation on this from Louise Day from the London School of Hygiene and Tropical Medicine. And finally, the parent perspective. And Silke Marder, the European Foundation for the Care of Newborn Infants, will take us through this. So I'm going to hand over now to Bernadette Delman. As I said, Bernadette, as the unit head, Child Health and Development at the Department of Maternal, Newborn, Child and Adolescent Health at WHO in Geneva, jointly led this work with Natalie Chapak, our Senior Medical Officer for Newborn Health. And we'd like to acknowledge Natalie today in this presentation. But Bernadette is going to present the work. Over to you, Bernadette.
Thank you, Olive, and greetings to everyone who is on this call. Olive, would you move the slide? It's my privilege to introduce the brief Nurturing Care for Every Newborn, which is part of a series of briefs in support of the Nurturing Care framework. We hope that many of you on this call are familiar with this framework that was launched in 2018 as a collaborative effort of WHO, UNICEF, the World Bank Group, the Partnership for Maternal Newborn Health, and the ECD Action Network. And that framework is a roadmap to action for helping children to survive and thrive, to transform health and human potential. So within the context of that roadmap, within the global community, we have been working and are continuing to work on a set of briefs that zoom in on specific aspects of nurturing care, either for a population group or for a particular cause or determinant of nurturing care to guide more on the actions that are needed. This brief, Nurturing Care for Every Newborn, was born out of a collaborative effort of the World Health Organization with the March Center and the London School of Hygiene and Tropical Medicine, the European Foundation for the Care of Newborn Infants, UNICEF, USAID, the Momentum Project, Save the Children, the ECD Action Network, and PMNCH. Next. So why this brief? As was already mentioned by Olive, the first month of life is a once-in-a-lifetime opportunity for children to begin the journey of unlocking their full potential. For that, they need high-quality care. They need nurturing care. And so we know that we have many opportunities for reaching newborns and their caregivers to make that possible, because over the past years, the rate of births that take place in institutional settings with skilled personnel has increased dramatically and is globally 80%. At the same time, we know that still an estimated 2.4 million newborns die every year, mostly from preventable causes, which are prematurity, birth complications, neonatal sepsis, and congenital anomalies. So quality of care is a key issue that affects many newborns all over the world. When we look at some of these factors in more details, we see that 1 of every 10 newborns is born preterm, and that 1 of every 7 newborns is born with low birth weight. And we also know that low birth weight and preterm birth contribute massively to newborn mortality. So improving quality of care and facilitating that every newborn receives nurturing care immediately from birth and that their parents are supported to do so is essential. Next. So what does it mean, nurturing care for newborns? The concept of nurturing care can be unpacked in 5 components. It means good health, adequate nutrition, safety, security, opportunities for early learning, and responsive caregiving, 5 components that every newborn, every child needs for healthy growth and development. So if we translate these components to the newborn period, then good health means preventing and managing illness, including the provision of evidence-based quality of care for small and sick newborns. Nutrition means optimizing exclusive breast milk feeding or breast milk feeding, including for very small and sick babies. Safety and security means providing babies with warmth, practicing good hygiene, minimizing stress for them, and enabling the primary caregiver, most commonly the mother, to be with the infant in a quiet environment. Opportunities for learning are essential even at this very early stage, and that can be done by measures like stimulating the baby's brain gently through touch, voice, and simply close contact. And then responsive caregiving means being aware of the signals which can indicate that the child is ready for food, has pain or stress, and to respond to those signals appropriately. And when children are provided with nurturing care, that supports the development of their brain, which in these early days and weeks of life is going on at a massive speed of both neural formation as well as the connections between the neurons to find the pathways for functioning. Next. So this first month is critical, it's precious, and so we need not miss this opportunity. And in this brief, we will be reminded of what are the essential actions that we actually know for a long time that are essential for healthy babies, as well as for babies that are small or maybe sick. It goes in greater detail on what can be strengthened in current services and systems to improve quality of care that mothers and newborns receive in maternity and neonatal facility. Obviously, there is attention to fathers and the broader community of caregivers around the newborn and the mother. And it then discusses what can be added based on evidence that is gradually unpacking to ensure that even when babies are small and sick and might need more specialized or intensive care, that infant and family-centered developmental care is being provided to them. So with these few remarks of introduction, I would like to hand over to my colleague Louise, who will elaborate more on the concept of infant and family development care. Louise.
Thank you, Bernadette. Could I have the next slide, please? So the brief includes a focus on infant and family-centred developmental care because this is so important for nurturing care. The term defines itself. It's about putting the infant and their family at the centre of care. It's about enabling health workers and parents to work in partnership to care for their newborns. And it's about care services being organised around the 4 core principles on the slide: dignity and respect, information sharing, participation, and collaboration. Next slide, please. The brief gives practical ideas how to implement infant and family-centred developmental care. And this is the figure 2 from the brief. In the green box across the top, education and training are framing this. At the bottom, thinking about the transition from hospital to home. And the 8 tiles in the middle give practical examples that we'll hear more about through this webinar. So from the left, supportive sensory environment, then moving across family support services, managing the acoustic environment, family access, and then the second row, support for parental-infant bonding, clinical consultation and supervision for healthcare professionals on supporting families, very early continuous skin-to-skin contact, and parental involvement. Next slide, please. This slide shows you the content of the brief, and it's in 3 parts. In the green writing, creating a nurturing environment for all newborns, and including a focus on how important caregiver mental health is. And the second green title, nurturing care for small and sick newborns, including promoting zero separation and supporting kangaroo mother care. And then the third green title, strengthening the health system. And the figure 1 on the left, the flower figure, we're going to explore more as we move forwards. And at this point, I'll hand over to Silke Marder. Thank you.
Thank you very much, first of all, for inviting me, because having a patient-parent representative on such a high-level agenda is special, and I'm grateful that in the meanwhile, this is still a standard that patient can raise their words. Thank you. Next slide, please. Yeah, when you see this figure of this graphic here, then you see that there are a lot of infant and family-centered care approaches, how to position a preterm baby or a sick baby, how to ensure that this baby can sleep. So patient-parent organizations have worked hard on developing standards on infant and family-centered care approaches, but we also want to see the details behind the screen, I would say. So what is really important for us parents? And we all know how important it is to provide breast milk and support parents in breastfeeding. But you need, of course, a plan to implement a breastfeeding strategy. And one of the key elements is a zero separation policy. When the parents, especially the mom, is not able and be allowed to be 24/7 with their child, how should breastfeeding really work? So therefore, it's important that in each unit is a philosophy of welcoming, so that the parents feel they are welcomed. They are the parents of this baby, so they are not visitors, and that there are facilities available that parents can, or the mother especially, can stay 24/7. If there's not the bathroom, that there's not anything where she can eat and drink and take a shower, how can she stay 24/7? It is important to provide skin-to-skin care, kangaroo mother care, and really support the bonding processes. And this from day one. That means zero separation policy and skin-to-skin care needs to be provided even a few hours or even at once when the baby is born. And that's not the case in many, many hospitals across the world. The parents and the babies and the whole family, they need respect. It needs to be looked how the needs are of these families. What do they need? What kind of support you as caregiver can provide this family? The fathers are not a second part of a family. They are also a parent and should not be separated from the child. So how can you ensure that also fathers can see their baby, touch their baby, and skin to skin care with their baby? And of course, also siblings are important. So this is something where you can think about how can you improve the care in the NICU to ensure that families can be a family of this baby and not being only a visitor. It comes the time when these babies are going home, and discharge management starts not 3 days before the baby is going home. I know from the colleagues from Björn Westrup, who is also talking today, that discharge management in the Karolinska Institute in Stockholm starts when the baby is born. So a really proper discharge management ensures that the parents are self-confident, that they feel as a parent, and this baby should go proper prepared from the parents' perspective to be in the end at home and have the best care. The mother is confident in breastfeeding and can take care of this baby. And what's going on afterwards, as a mom of a 25-weeker now being 24 years old, I know very well how important it is to ensure really an adequate long-term follow-up, that these babies really can go home and thrive healthy. And therefore, the start is in your unit, in your hospital, to ensure that parents are self-confident, that they can go home proper prepared, and then finally have a good follow-up, that this baby can thrive. Next slide, please. And we all know how we all suffer at the moment on the pandemic. And the parents really suffer a lot at the moment, especially for the ones who are born preterm and sick, the babies. So we did as EFCNI, together with our initiative GLANCE, the Global Alliance for Newborn Care, a survey where we asked parents, how is the situation for you in the pandemic? Because we heard from many, many parents all over the world that they were separated, that they had no access to their baby. So therefore we asked our parents. We got finally 2,103 feedbacks from our parents from 56 countries. And one of the publications is already available. And I have to thank my dear colleague, Johanna Kostense, who was responsible for this. And the full report with all the data of all the countries will be available on November 11. So 48% were permitted to be accompanied from another person during birth. That means that only 50% of them had the opportunity to have a partner with them at birth, but the other 50% has to give birth alone. 74 of mothers and 56% of the fathers were allowed to be present with their child. That means that 25% of mothers had not access to their baby at all. And 50% of the fathers had no access to their baby. And finally, 21%, no one had access in the end to their baby. That means they were until 4 months, sometimes alone on the NICU, and they got their baby at discharge. How should these parents feel as a parent, and how should breastfeeding work when we have not access to our babies? Also here you see some numbers on breastfeeding. 52% of the mothers were highly encouraged to breastfeed, 25% somehow, and 80% not at all. So we all know how important breastfeeding and breast milk is for the tiny babies. What can we do to really change this? We are middle in the pandemic. That's really important. So how can we ensure that we provide the best care for our babies, and how can we ensure that parents and babies can stay together and that we have a nurturing care situation all over the world? Next slide, please. I want to close with my presentation with this picture, because this picture says more than many words. You see the love of the mom, you see the fun of the baby, and you see how this bonding had happened in the past. And this is what we want for our children. We want the best for the babies, we want the best for the parents, and we want that these parents can support the baby to survive, to thrive, and to be a happy person later in life. And I would like then to hand over to Bernadette to go to the next part of the session.
Thank you very much for your remarks, Silke, and for illustrating with data the challenge that we have, but also the opportunity. So colleagues, we are now going to proceed to part 2 on creating nurturing environments, and we have a distinguished panel here that at this occasion I'd like to thank for their contribution to this brief, because as you will have chance to read it in more detail after this session, you will find small case vignettes of stories that have been provided by each of the presenters. So I'd like to start with Dr. Sharafidin from the American University of Beirut. Dr. Lama, in the University Hospital in Beirut, you have made important adaptations in the neonatal intensive care unit. Can you tell us a bit more about these changes in practice and how they impact on the development of newborn babies and the well-being of their parents? Over to you.
Of course, yes. Thank you, Bernadette. Thank you very much for inviting me to be part of this very important panel. Next slide, please. So our unit is a small unit, and as you know, in Lebanon, we're a small, low to middle income country, and we don't have much resources, but we realized very early on that developmental care is important. So we implemented a developmental care and early intervention program in our NICU using the NITCAP framework, and we started training in 2013. In 5 years, we were able to have 4 nurses trained in individualized care, and the culture of developmental care was spread throughout the unit for all the nurses who care for our babies. As you can see on the slide, the components of developmental care that were eloquently described by Bernadette and later on by Louise are depicted here, and they are very much aligned with the components of nurturing care. We were able to shift the culture in our NICU from a task-oriented culture to an infant and family-oriented care through quality improvement projects that I will talk about in a minute. And this tackles the aspect of good health and advancing and providing quality care that is evidence-based. For the component that is the nutrition component, we are promoting breastfeeding through the promotion of kangaroo care and having a breastfeeding baby-friendly hospital. And by involving parents in the care and treating the nurses and the staff as caregivers themselves, we were able to empower them to become responsive caregivers. And by providing a safe environment through education and implementing quiet time, for example, and dimming the lights, we were able to provide a safe and secure environment. And the last component is the opportunities for learning. We also promoted from early on, encouraging staff as well as parents to talk and sing to babies, etc., etc. So next slide, please. So what are the changes that we saw? So honestly, we saw remarkable change in the care, all the way from the impact on infants, where we can see, for example, when we implemented a quality improvement project on positioning babies, they were less stressed, they had less events, less apnea, less bradycardia. And then when we taught the nurses on how to cluster care and provide care based on the behavioral cues, we could see that reflected on the babies. By involving parents into the daily care, for example, providing swaddled bath or encouraging them to do kangaroo care and be present on ground and participate on ground and ask questions. We also involve them into many activities on a regular basis, and this is before the times of COVID, where we would hold regular sessions on raising awareness about the importance of kangaroo care and how that will improve not only the outcome of the sick babies, but also the well-being of the parents, mothers and fathers alike. They were also involved in World Breastfeeding Week, where they were encouraged to provide more breast milk. And more recently, we encourage them to participate in the readathon week, where it's ongoing this week, where they are encouraged to come and read to their babies whatever they like. We also were able to, like I said, shift the care and empower the staff by providing education and workshops and also materials in Arabic. And we were able to have policies changed and with the support of our leadership. Now with the COVID-19, everything has shifted to online, and this is a big challenge, but we were able to do it. And Silke just mentioned the transition to home, and we were able to be successful in that by implementing a follow-up clinic where sick babies are offered to be followed and then provided with education material for early intervention. And we do have Arabic material for those who are interested to share. And I see that my time is up. I'm happy to answer questions later on. And thank you again for listening.
Thank you very much, Dr. Lama, for this inspiring presentation illustrated by beautiful photos and highlighting different aspects of the work that you look, not only concentrating on the infant, the parents, the staff, and what happens in terms of follow-up. Thank you very much. I would now like to introduce Professor Arti Maria from New Delhi, India. Welcome, Dr. Arti. We would like to ask you whether you can speak a bit more about family participatory care, which was approved in 2014 by the government of India for countrywide scale-up. Can you tell us briefly what family participatory care is and how political will was created at the highest level for its scale-up? Over to you, Dr. Arti.
Good evening, everyone. Good morning, good evening, and good afternoon. So I'm Arti Maria. Without wasting time, family-centered care is nothing but it's an approach, it's an attitude, it's a mindset, a concept that aims to develop and nurture families' role in partnership with the healthcare team in the care of a patient. Next, please. As you can see, it rests on three pillars, mainly participation, respect, and collaboration. And this is for benefit of and care of a small and sick newborn, collaboration between the healthcare provider and the parents or the primary caregiver, which is the mother primarily. Next, please. I think we all are familiar with what family-centered care is, but I would just like to take you through this model, this schematic model that we have sort of tried to depict. So conventional model of a care of a sick newborn is mainly provider-centric, in which the provider, the healthcare provider, takes the role of power, control, and authority. And the challenge, of course, is a human resource constraint, and therefore the outcome invariably is compromised quality of care. When it comes to the client perspective, the family, in the conventional model where the provider-centric care, the client has passive role or minimal role of that in a silo. The challenge for them is separation from their small sick newborn, and outcome is unmet needs of social, unmet needs, and that leads to anxiety and mounting stress. What does family-centric care does? It creates a paradigm shift, and from the power role of the healthcare provider, it becomes a responsibility. I would say care sharing. Although the responsibility still rests with the provider only. However, this is a collaboration, a therapeutic alliance between the provider and the client. So what happens as a result? The provider has work sharing. Therefore, the work burden is less. Outcome means the quality improvement occurs. and the parents being involved and participative ownership is there. So they develop caregiving competencies and trustful relationships because of transparency of care. And this also leads to continuum of care, which is created. So overall, there is improved health outcomes, which are likely to be a cornerstone for continuum of care. So it's a win-win situation. Next, please. Now, I want to take you through this journey of family-centered care in India, how it has influenced national policy and standards in India. At facility level, where we started and innovated this concept, which is a LMI, low middle income country setting of India, we incidentally, because of the HR constraint, we had started involving the parents just because we didn't have enough staff, and we were trying to overcome the challenge of meeting the quality by involving them, teaching them, training them on one-to-one basis. And this led to incidental discovery in 2007, when we saw the anecdotal observation that that the parents' involvement was doing wonders. It was allaying their anxiety, and meeting their children all the time was a big advantage for them. And even the work sharing on part of the healthcare providers was a wonderful thing. So it was a mutually desirable situation for all of them. And then this was anecdotal observation, but what we did, we went ahead and did a randomized control trial because we wanted to generate evidence. And then we started disseminating that through publication. Then we led to tool development by key national experts. There was a validation committee, and we developed the audio-visual training guide to standardize the intervention. We also developed the resource materials, operational guidelines, and development of implementation and monitoring framework and recording formats. It was over 2-3 years that we did. Meanwhile, NIPI had offered, because we had gone around to people and said that please, as if selling this idea. And eventually we were able to convince NIPI and they, Norway-India Partnership Initiative, and they agreed to do a pilot implementation in 2014 in 4 states and 5 districts. 5 districts in 4 states. And there was an overwhelming response from the stakeholders, both the providers and the families. In fact, it was so obvious that we didn't have to, after that, it was not much of a struggle. The practice was chosen as one of the key innovative best practices in newborn care at national level. And this gave us an opportunity to share and disseminate this at a national level, and as well as technical and various professional fora. Findings from this pilot implementation and operational research led us to iterative improvements in the tools and guidelines that we had developed. And what were our key findings? Key findings were that family-centered care improved quality of care. It was a winning strategy for KMC implementation. We've been struggling hard, but through family-centered care, it became rather easy. It was an integral part. And the key learnings were that identification of a local champion who's self-motivated and driven can make and drive this change rather easily. Also, establishment of model resource centers, convincing the key stakeholders, including the government and state and the national governments, and adaptation of tools and local translation may be required as per the social and cultural context of the place. So family participatory care was launched as a national health program in India in July 2017, after all this long journey. And nationwide advocacy and scale up started happening at district levels. Also, there was growing international interest in the intervention, just as why I'm here today in front of all this august audience. By now, family participatory care is integral to existing health programs and not as a vertical program. Political will and national and state governments' involvement has been vital at all stages. Next, please. And that's it, actually. Thank you so much.
Thank you very much, Dr. Artif Maria, for sharing both the concept as well as that fascinating journey that you have gone through, which illustrates some of these key aspects that are discussed in the brief. Having champions and good models of care is essential then to motivate the action to take create a political will and create the investment for scale up. And you have successfully done that in India. But as you have articulated, this is a journey where it continues to be in progress. And so refining the package and kind of being at that level of quality to sustain that is very critical. Thank you very much. We now
Thank you so much. Yeah.
We now go to the next speaker, and I'd like to introduce to you Mrs. Ylva Törnström-Blomqvist from Uppsala University Children's Hospital. And Ylva, in this case study that you shared, there was an interesting quote that said, from a neonatal nurse, that said, "What you do often, you will be good at." So can you elaborate a bit more why this statement is important and how it should influence the way health workforce and systems can be strengthened for infant and family-centered developmental care? Over to you.
Thank you very much. Do you hear me now?
We do hear you, Ylva.
You're fantastic. Next slide, please. So, dear organization committee, and thank you very much for inviting me. I am so happy and feel really honored to be here with all of you today. And of course, I'm really nervous because I know that all of you who are listening are interested in this area. And I understand that you all have a huge clinical experience from different conditions all over the world. But in our Swedish context, with paid parental leave for both parents, so they can really be at the NICU 24/7 without losing some money. And in a high technology standard, which in fact, in practice, often be a hindering factor for us in Sweden. We can see hinders for infant and parent closeness. That these hinders are, for example, baby clothes, baby beds, incubators, NICU staff attitudes, and NICU staff that want to be and have control over the situation or over the infant. And further, we can see that facilitators for infant-parent closeness is or parental leave, that we always have a parental bed at every infant's care space, which clearly indicates that at least one parent can and should be with their infant 24/7, even at the NICU. Staff attitudes, which can both be a facilitator and a hinder. The NICU environment with parental kitchen is a really good facilitator. To have a good cooperation between the NICU staff and the maternity ward, and that all managers, doctors, and other NICU staff believe and think that infant-parent closeness is important and that they are constantly working for that is really important. And we are well aware of that it's not easy to be a parent of an infant in need of care at the NICU, but to not being allowed to be present or involved is, in our experience, much more difficult than being allowed to be present. And as you can see in this photo, we strive to, in a safe way, achieve closeness, despite that the fact is that at our NICU, we have a high technological environment and that we often care for severely ill and extremely preterm infants, someone born after 22 weeks of gestational age. Our experience is that the best and the most simple way to achieve closeness is to care for the infant skin to skin. And by the way, it's important here to mention that we have no infants' clothes at all at our NICU. We have seen clearly that infants' clothes is a major hinder for skin-to-skin contact. Next slide, please. Furthermore, in our context, it has become clear that if we want to have parents to be present, We cannot force them to choose between their older children and the new infant. So we let siblings be at the NICU and we involve them in the infant's care. Siblings are allowed to be at their NICU and they are allowed to care for their younger sister or brother skin to skin. And we find out that they are so important. It will not be good for the parents to be forced to choose between the children. Which of them should they choose and be with, for example? So we always try to keep the family together. And my take-home message today for this short presentation are what you do often, you will become good at. Because we mean and we think that if you often separate infants from the parents and for example, put a lot of infants in incubators, that's what you and all staff at your NICU will be good at, and you will be used to do that. And the same goes for the opposite. If you always work for togetherness and closeness and early skin to skin and parental and sibling involvement, that's what you will be used to do and you will be good at it. So always make sure that parents are and maybe can be present with the infant 24/7. It needs a welcoming NICU environment with space for parents around the clock at the infant's bedside, not in another corner at the NICU. You need to have the parents at the infant's bedside. Maybe you can use parents' chest as the infant's care place, I mean skin to skin. Having parental beds at the infant's care space is, according to our opinion, very, very important. No armchairs or chairs in the world are comfortable to sleep in throughout the infant's whole NICU stay. By facilitating and helping parents, we as staff can by not facilitating and helping parents, we as staff can mistakenly believe that they do not want to stay with their infant. But this is our job as NICU staff, no matter of profession. It's important that we help, support, and make it easier for parents to cope with the situation. You need to involve and welcoming siblings and relatives, and involve parents and let them actively participate in the infant's care. Give them important things to do as skin-to-skin care, but also things as tube feeding and so on. And all of this that I mentioned, you need to start early. And I mean really, really early, directly after birth. And you need to inform the parents before the infant is born. So, to summarize, what you do often, you will become good at. So don't separate infants from their parents. Thank you all for letting me present in this here. Thank you.
Thank you very much, Ilva, for this powerful message illustrated by beautiful photos as we saw coming through the chat box. Not only have you spoken about the care within the facility, the attitudes, what is needed to create that enabling environment, you have gone beyond that to speak about policies as well that are needed to allow caregiver parents to be with their children for as long as it needs. And so that's a dimension that we should not lose sight of either in the broader picture. Thank you very much. We now proceed to the next speaker, which is Dr. Sakura de Leon Mendoza from the Philippines. And as many of you may know, the Philippines has a long history of efforts to improve the quality of newborn care. Starting with the baby-friendly hospital initiative and then beyond. So Dr. Sakura, what have been essential steps for building and sustaining capacity for developmentally supportive care within the health system? And in your case, you may start at the early ages of how the Philippines started its road for quality of care for every newborn. Over to you. Mm-hmm.
Thank you, Bernadette, for that kind introduction. A pleasant day and evening to everyone. If I may have the next slide, please. In accordance with global recommendations, advocacies and programs that aim to nurture the newborn are adopted by the Philippines healthcare system and professional societies to the extent possible in order to maximize potential benefits to the target population. In the case of breastfeeding and kangaroo mother care, certain laws have to be enacted in Congress, and healthcare policies from the Department of Health need to be promulgated or issued to facilitate the delivery of services. Despite this, however, actual implementation on the ground falls short of expectations. In this regard, the National Health Insurance System, also called PhilHealth, to which most healthcare facilities are affiliated, integrated the advocacies as early as 2005, beginning with the Mother-Baby Friendly Hospital Initiative. Next slide. As of July of this year, a total of 1,871 healthcare institutions out of nearly 2,000 licensed facilities are affiliated with the Philippine Healthcare Insurance System, by which services are rendered with minimal to no out-of-pocket expense on the part of the patient. Integrating the specific programs into the insurance system was the strategy adopted by government to facilitate service provision at all levels of care in both private and public institutions. Note that availment of the maternity care packages totaled more than the number of affiliated institutions, simply because birthing facilities can be affiliated and avail of this insurance system. Next slide. Under the PhilHealth program, newborn care and related packages of services are provided by accredited institutions to the target population, and renewal of such accreditation is subject to compliance with requirements contained in the above circulars issued on the years stated. In 2017, issuances to support the preterm, sick, and small babies were provided in a Z-benefit package, wherein the services included early essential newborn care for small babies and inpatient kangaroo mother care. The benefit package was designed to provide financial risk protection for the patients so that they can access both preventive all the way to catastrophic care, as well as a financial risk protection for the hospitals providing such services. This package complements all the previous health benefit packages for mothers and newborns. This was also followed by an issuance on the care of children with developmental disabilities that included NICU graduates, among others. The last circular was issued in pre-pandemic 2019 to support primary health care and basically ambulatory and outpatient care for all life stages, which included kangaroo mother care for low birth weights and early childhood developmental screening, as shown in the next slide. Next slide, please. So while the DOH policy was promulgated in 2017, the National Health Insurance System did not adopt the service for outpatient care until 2019. All accredited institutions need to be pre-authorized to provide the package of care to patients upon compliance with the requirements which are stipulated by these circulars. To date, not all level 3 hospitals have been able to comply with these requirements to be able to provide the package for preterm and small babies. With the pandemic situation, site visits and accreditation by PhilHealth has been limited, and provision of such services remain a challenge. Notwithstanding these challenges, the strategy certainly capacitated both the patient and the hospitals in sustaining their implementation of the programs that nurture the newborn towards a healthier childhood. Thank you very much.
Thank you, Dr. Sakura, for that, showing us that pathway And when our participants will read the brief, they will realize the central role that the Philippines Kangaroo Mother Foundation, of which you are the president, has played in catalyzing some of these changes. So again, the issue of championship, having leaders that will be able to help advance on the path is critical. And so thank you and your colleagues for paving that way or contributing to that way in the Philippines. Colleagues, we are now moving in. Thank you very much. And we will now have our last speaker on this panel, and it's my pleasure to introduce Dr. Natalie Chapak from Colombia. Dr. Natalie, you have contributed to brief with a story about your experience in Colombia under the COVID-19 pandemic, where, as we have seen in many facilities, measures have been taken that were not to advantage of zero separation or the experience of care of both clients and mothers and newborns in particular. So could you share in a few messages with us what you have done to ensure continuity of quality of care under these circumstances, where maybe even at the beginning the data were not there, that would sort of put you in firm shoes to see whether what measures you could take in a safe way. Go ahead, please. Mm-hmm.
Thank you very much for this invitation to speak about the experience of protecting the skin-to-skin contact and the breastfeeding during the pandemic in Colombia. So next one. Next. What I want just to explain is that first you have to understand that kangaroo mother care is scaled at a country scale in Colombia since more than 20 years, I will say, and very organized for 10 years. So that was very important. And who are the actors? The health ministry, and they have guidelines actually updated in November 2017. You have the Colombian Society of Neonatology and the Kangaroo Foundation, which is registered in Colombia as a research, monitoring, and diffusion institution. So you have 200 neonatal units doing intra-hospitalized kangaroo and 53 ambulatory programs around the country and in the big cities. So each year we will do an annual national workshop, and we have two tools, which are a KMC WhatsApp, where we can ask for help for transfer a baby, but we can share paper, research, lecture, and we have a retinologist workshop, WhatsApp, very important because we want to avoid any blind infant because of the use of oxygen in premature. Next one. Next slide. I will go very quickly on the slide. So the first message was collaborative public health action between the actors. Yes, and the health ministry organized us, we publish recommendation, they publish resolution, we did a survey, we modify the recommendation, the health ministry published the last update of their resolution. Next one. Next one. So the survey in the middle, the big peak of the pandemic showed how parents' visit go down, the duration of the visit. They were able to separate in the NICU the COVID and not COVID spaces. Member of staff positive, it was very low. There were rooms for mother and baby in half of the unit. We look at the hours in kangaroo, but anyway, some of them limit up to 1 hour only of training. And we look how many newborns were admitted, and it was very low also in the majority of units. Next one. So you can see before the pandemic, the adaptation to position and nutrition, and during the pandemic, it's still like this, step by step. I hope we will recover what we were doing. Next one. So you can see that in April 2021, neonatal COVID was 0.05% of the total of COVID cases in Colombia. So we continue that the non-COVID space intensive care, intermediary care, minimal care unit. I will not speak about the COVID space, but it was possible for a family member to carry the baby also and to send photo. Next one, next. We suppress collective activities, next one. So the second message, that's very important, the WhatsApp. The WhatsApp was key. The WhatsApp allowed the communication between coordinator of unit, coordinator of kangaroo program, health ministry, sending photos, exchanging new papers and data, solid data that could be used to better the practice of kangaroo. Next one. Next one. So the survey in the kangaroo showed us that they were able to have EPP for all health workers, able to do the phone call before the appointment, a triage station. They were open at least from Monday to Friday, at least 8 hours, and the number of baby included with COVID and health worker positive. Next one. So it was very important to collect data. You can see, of course, it's not the same, but mothers were happy and coming and refused more than one virtual consultation. Next one, next one, next one. Solution, strict cleaning protocol. Next one. I have a chronometer. And here you can see that all mothers are creative and innovative. So the rule was protect yourself and you will protect others. We must remember that these people are coming by bus and it's 1 or 2 hours of transportation to come. Next one. And last one, the third message was that the challenge was to act based on evidence and not on emotion, not to lose what we were able to build. That was the goal. Thank you very much.
Thank you very much, Natalie. I know you had so much that you wanted to share with us today, and thankfully we will have the slides and people will be able to go back and look at some of the data. I think it's been quite impressive to see that even though there has been so much happening and so much moving so quickly, that you've been able to take steps that are evidence informed and then also continue to collect data in real time and use that to keep pushing the agenda forward. And I just want to reference also that we had a webinar last July on the topic of breastfeeding in the context of the COVID-19 pandemic. And I know there's been a few questions that have come in about how do we think about nurturing care for newborns in the context of the pandemic. So we'd encourage you to go back and look at some of the information that was in that webinar, and we can also share that with you later. So we're going to turn to some question and answers. We will probably have a shorter round than what we had initially planned for. If you can go to the next slide, Ola. Just to let you know, we have received all your questions. We have been keeping track of them. If you would like to continue the conversation after the webinar today, we invite you to go to the link that's on the page. We'll also put it in the chat for you. And all the questions that haven't been answered today, we will put them there and we can continue to respond to your questions there. And that link will also invite you to join a community of practice around the quality of care for maternal, newborn, and child health. So maybe we can stop sharing the slides, and if all the speakers would like to turn on their cameras. Wonderful. Great. So there are a number of questions that have come in, and I think maybe we will take one question that would allow everybody to say a few words. You've given lots of concrete examples of how we can think about nurturing care for newborns. And I know people have asked for more examples, so I would encourage those of you that have asked that to go back and look at the slides again, listen to the recording, also look at the brief. There are many examples provided in the brief. So we won't use the time here today to talk about what we should be doing. I think the message was quite clear to say it needs to start early, right at birth. We don't need to wait, that nurturing care starts at the beginning. But the question that has come up is, well, what are the challenges that remain? We know what we need to do, but we're not there yet. We're on the journey, we're moving in the right direction, but how do we get there? So from your perspective, what are the challenges that remain and what is something that we could do? And if those of you that would like to respond, if you could maybe share one challenge and one action that we could take, how could we move forward? Who would like to start?
I can start.
Go ahead.
Sorry.
Sorry, Artie, I think I see you.
Lama.
Can I say?
Yes, go ahead, Artie.
Yeah, so I think it was a very, very long after that we realized what the real challenge was. We really tried hard, and I think that learning has really stood with us. And I think I realized the key challenge was getting the healthcare provider on board. So we always thought, you know, it's all about training the mothers and in getting them engaged and having them to participate. It'll be a challenge to, you know, they are coming from various low socioeconomic status, maybe illiterate many a times, and to get them to do all these activities and then understand the importance of them. And so this was in our mind that that would be the biggest challenge. But to our dismay, we tried even doing that, you know, having the mothers to come regularly and everything. We really tried hard to train them. We developed the audiovisual tools, which are culturally sensitive and very much in local language, and everything we tried, made it as simple as it could be. But still we realized that it was not coming up the way we wanted. So we realized, where was the bottleneck? The bottleneck was really the healthcare provider. So if the healthcare provider, like, see, the mother is always game for it, because mother is just waiting to be there by the baby's side and do some activities rather than be sitting outside in a silo and doing nothing and just being anxious and you know, worried and all that. But the healthcare provider, why should he do it? In fact, he's uncomfortable, he or she is uncomfortable that the mother is allowed into the NICU. Now she can see whatever is being done. So they are uncomfortable. They see mother figure as a watchdog. You know, they can't be like at ease at all. Even hand hygiene. Now mother knows hand hygiene is so critical. So mother sometimes points out that the doctor hasn't washed hands and, you know, he's touching my baby. So obviously the doctor, healthcare providers would be a little uncomfortable. But if you can get them on board, and how do you get them on board? You get them on board by actually sensitizing them, making them understand how vital this is for the baby. You're spending so much time and energies and efforts in saving this baby. But what if he goes home and he is not able to make it through? He succumbs just to infections and other things. So if they understand, and you know, quality of care means healthcare experience. And when parents thank them and go, then they realize that it is so, so important to have them on board. So then eventually when these doctors, they all nurses and doctors, they have come on board by seeing the effect of it, the benefit of it. So now it's no more a challenge for us, because it's become a integral part of our nursing care and a you know, newborn care. And they are actually quite motivated, and it happens with time. Yeah.
Exactly. It is time. It is a journey. As you say, it is the health workers. We need to get the health workers on board. And as you said in your section of, it's the mindset, it's the attitude that comes first, and then we look at the behaviors also. Lama, and then Natalie.
Yeah, I was gonna say exactly the same, that the biggest challenge is shifting the culture from providing a quality care that is really task-oriented to really individualizing the care and looking at the baby and engaging that baby, and then delivering the care based on the baby's needs and the family's needs.
Right.
And by having the buy-in of the nurses is extremely important. And then you can get that by showing them how, when they shift this care, how the baby does much better, and how the mom or the father is helping them. And I agree that they used to see the parents as the watchdog, but now when you shift the care to asking the parents to be partners in the care of the child, they can see that, you know, they're taking away some of the burden of the work from them, and they see that as a positive.
Exactly.
And this
What's
has
the value
helped
for them? How does it make their job easier?
Exactly.
Yeah.
Exactly. Yeah.
Thank you. Thank you. Natalie.
Yes, no, I just want to say that we never had problem with parents. I mean, independently of the education, But what is true is it's very difficult to change practice of all the team. Yes, because we learn something and you are changing the practice, and it's very difficult. So I think we did it with psychologists. I mean that it was a decision to change, and the psychologists began to work with all the staff to be able to change the way they were looking at the parents. And the third thing, when you take the decision, for me, it's kangaroo mother care. Nurturing care is kangaroo mother care, which is with everything. Yeah, the mother is here, skin to skin, breastfeeding, early discharge at home, etc. So to do that, you must give the tools to the staff and the tools to parents. Yes, if you do it in a place and nobody will give something to eat to the mother, how do you want her to do 24 hours? Or something to drink or a shower? It's true. Everything is possible. They want to stay with their infant. Once they understood and they can see the effect, parents are not a problem. The problem is, and the tools have a cost. If you don't put a cost of implementing something like this, it will not work. As my colleague Suki said, you have to put the cost. So if you do everything at a reasonable, something reasonable, a minimal, how it will cost me, it will work better at a level of health ministry, actors, director of a hospital, and this kind of thing.
Exactly. Thank you. Yeah, I think it's, as you say, I mean, we have to get the health workers on board, but then we also have to arm them with the what they can do, because it's not just what you shouldn't be doing, it's what you should be doing and how you can support a parent to do that, and then equip them with the tools and resources that would enable them to do that. Silke.
Yeah, thank you. There was also a lot of question of how to convince in the end, or how to ensure that this can be financed. And I can share, we have an organization, EFCNI and CLANS, where we establish also strong parent organizations across the world. And what we can share is that even collaborations between parent, patient, advocate organization, even in collecting donations for providing this training to healthcare professionals is also possible. And even in low-income countries, there are in the meanwhile several patient-parent organizations who are building up, asking for grants. And what is really important, we have done this, I'm coming of course from a rich country and rich town, Munich, but also here we had big challenges, visiting hours, just a few a day. And it was so hard to convince the nurses about increasing the infection rate and to combine this soft skill issues with this hard medical evidence, what doctors often think is more important than this emotional bonding in kangaroo care. And we really worked hard on a minimum of half a year, where we collaborated with the hospital administration. We had a meeting, a coffee drinking with the chief doctor, with the chief administrator, and also with the chief nurses to ask about what they wish, how they want to implement it. We did a survey with all of the staff members, the 120 staff members. What are their fears? What are their concerns? What are their hopes even for such a training? And after looking really in this, we set up a training where we finally trained all the 120 people. And the willingness of the hospital was they provide the staff for the training, and we as an organization, we financed it. And we also got special discounts from the trainers. So finally we could train the hospital. And we also can ensure now that it is sustainable, because all the new stuff, all the new nurses are trained now internally, and you not need continuous training outside. You have it inside, and now in the end forever. And that is something how sustainable and really strategically you train in the end, because one nurse with 120 nurses in a big hospital, you will not change the world. She will even have harder to, in the end, in this team, thinking family friendly, and the others don't want it. So the others will be against her or him. So this is really something what I can share. Of course, it's a rich setting, but we know we have several parents today here as participations. We have done this in Greece, we have done it in Africa, we have done it in the US, in Canada. So we really know how to collaborate and how to convince. You cannot do this from one day after the other. It needs time, it needs patience, and it needs also strategy.
Absolutely. Absolutely. I think, you know, we've all had these experiences, and it's how do we bring those experiences together and then leverage those opportunities. I can see in the chat, somebody is talking about how we work with grassroots organizations, how we think about the financial resources we already have, but think about it in a more creative way. You know, whatever we are calling what we do, it's not the names that we give things, it's are we making sure that the services are being provided and that they're getting to everybody. And sometimes it is a matter of just looking at what is being done, how it's being done slightly differently, and then also looking at the resources we have, both human resources and financial resources, and thinking about it slightly differently. I do apologize that I'm not going to be able to give everybody a chance to come in, because I think we have run over time, and I want to make sure that we get to hear from our partners. Sakura, I see you want to come in quickly. Go ahead.
Just one, yeah, just to share. For Silke and those who are doing training, we do team training for healthcare units. We don't train one nurse. We train a team of doctor, administrator, nurse, midwife, and social worker at one time, and they become the training team for the entire hospital. So all over the Philippines, we have regional centers of excellence doing their own training. And so that's something you might want to consider. Sorry, I just need to add, the healthcare insurance system that was put up in 2017 for this purpose is kind of restrictive in a way, because the requirements are important for them to comply with. So the facilities need to upgrade in order to be able to avail of this insurance system. But it really provides the system to sustain the capacity of our facilities. Thank you. Thank you, Sheila.
Thank you. Thank you. And like I said, we can continue this conversation once the webinar is over. We'll put the link again in the chat for those of you that want to continue. And clearly there are many, many experiences among the group here, both among the speakers and those of you that are typing in the chat. Many of you have already been sharing lots of experiences. And I think this is an opportunity to share that, look for ideas that have worked in different places, and cross-pollinate where we can. I'm going to hand over to Shikufe Zonji from the ECD Action Network, who will lead us through the next part of the session. Thank you very much.
Thank you, Sheila, and thank you to the panelists. Hi, everybody. My name is Shikufe. I'm the Global Technical Lead with the Early Childhood Development Action Network, and it's my pleasure today to facilitate a reflection with a few esteemed partners. So maybe to the next slide, Owen. So today we'll have with us Lily Kack from USAID, Bjorn Westra from Karolinska Nidcap Training Research Center, Joy Lawn from the London School of Hygiene and Tropical Medicine, Alison Morgan from the Global Financing Facility, and Nina from Momentum. And so maybe we'll take the slides down, and thank you. And it would be great, Lily, if you can kick us off in this reflection series. I'd love to hear from you. You know, given the presentations you've heard today, what has been a big key takeaway for you? And maybe share an insight from your own organization, from USAID's perspective, about what you think is necessary to ensure every newborn receives nurturing care. Over to you, Lily.
Thank you, Shikufe. Thank you for inviting me to share my reflections on this very important brief on nurturing newborn care. I'm very excited with this brief because it marks the evolution of the Global Newborn Health Program, presenting a paradigm shift in the way we implement programs for newborns from a narrow focus on survival to a focus on the full physical and mental well-being and development of the newborn. What is important is that this brief builds on the overarching nurturing care framework and dives deeper into explaining how we can operationalize nurturing care for newborns. It unpacks the components of a bundle of evidence-based interventions with the examples of the IFCDC framework. I'm learning some new acronyms. IFCDC, Infant and Family Centered Developmental Care, and also the NIDCAP framework, which is the Newborn Individualized Development Care Program, which we just heard about. Very importantly, it includes the central role of parents as partners rather than as visitors or passive recipients in the care of the newborn, and the importance of paying attention to the mental health needs of the parents as well. We heard some very interesting country presentations, and hearing from the country presentations encouraged me because it proves that implementation of nurturing care and developmentally supportive care of newborns is doable. It has long been USAID's priority to support countries to end preventable newborn deaths. It has now become equally important for USAID to advance the global agenda on nurturing care for newborns so that they not only survive, but also thrive. We are now paying special attention to nurturing care as an integral part of small and sick newborn care to optimize their neurodevelopment. This is not going to be easy. It's not a simple quick fix. It will require addressing broader health systems issues, including the health workforce, equipment, data management, spatial arrangement in the health facility to realize the goal of zero separation of moms and babies, and various policy changes, etc. But we know that some countries have moved forward and have lessons to share. Going forward, we look forward to working with partners to learn from their country experiences and supporting the development and implementation of a model of nurturing and developmentally supportive newborn care in all countries. Thank you.
Thank you, Lili. That was great. Thank you so much for sharing that. Bjorn, over to you. What insights do you have to share with us? What reflections and messages do you bring from your organization perspective?
Well, first of all, I'm very impressed by all your work, and thank you, Louise Tinadate, for your very nice summary of the IFCDC in the brief. We are so grateful that you have highlighted that. And one aspect that I might just highlight again about IFCDC, it's based on the sensitive behavioral communication of the infant and the individual infant. So it's individualized care, which is very important to remember. And also systems change. We need to repeat that many, many times. But remember, we need to have obstetrics to be on board to ensure zero separation and KMC for all. We need to implement mother-infant couplet care in order to achieve this. And that is well described on page 8 and 10 in the brief, so I will not go further, but you need to care for the mother and the child in the same geographical place, same ward. And also I would like to highlight a few points of that Dr. Arte Maria pointed out in her key points. And she said so well that IFCDC improved quality of care. It's a winning strategy for KMC implementation. So Natalie, in order to get KMC for everyone, we need IFCDC as well. But also, Dr. Arte pointed out that the key learnings is to identify local champions and to establish model resource centers. I think you're so right in that. And Dr. Lama, she highlighted, of course, the central role of NIDCAP and FINE in the IFCDC's education. And please remember about the discussion on the staff. One of the IFCDC standards is actually on clinical consultation and supervision for healthcare professionals on supporting families. I think training them in IFCDC and also offering them clinical consultation and supervision, that will help a lot. But remember, political will and national and state governments are key, and we need to continue with the systems change. Thank you very much. I'm so happy about this.
Thank you so much, Bjorn, and it's music to my ears to hear both Lily and yourself highlight the importance of systems change. And I just want to bring in a message from the chat that we just got from Reina Lisa Enriel, who says, as the only neonatologist in a government hospital with 1,000 deliveries annually, we need the family to share the responsibility in taking care of their sick, premature, and small babies. We were able to shorten hospital stays and save precious hospital resources. And I think that's a perfect example for looking at the family as part of the system that we are trying to influence. So with that, I'm going to ask Joy, we'd love to hear your insights as an academic and a researcher, and share your reflections.
Yeah, thank you so much. And just such a privilege. I think on reflections, I heard a lot of P's. So we've got a panel here with many powerful women. Happy to see some men as well, because we need that. We have many perspectives, both from disciplines, but also from every corner of the globe and from different parts of this pathway. And then the biggest thing I heard was a paradigm shift. And I think it's easy to say paradigm shift. It's extremely hard to shift a paradigm in practice. I just reflect back to being a neonatologist in a hospital in Ghana with 12,000 births a year, now 25 years ago, and having the baby-friendly hospital initiative team come. And after precisely 4 minutes, they said, this hospital will never be baby-friendly. And it was so dispiriting. So I want to say to all of you out here, you're seeing people who have already maybe been doing this for 10, 15, 20 years and are still shifting a paradigm. But I want to say to all of you, have courage, because we're really at a tipping point. So we now have in our hands the power of evidence. Take this brief, don't just use it, take it to your policymakers, use it. Don't just have it look nice on a shelf. It's beautiful. Thank you, Bernadette, Ornella, who we highly respect, and Louise and others who have contributed. It's got power, use it. And then practice, really think how to do that. And then I want to salute Silky and her team. Parents are not just here to offload care on when the nurses are over busy. They're here because they're the ones who care most about their babies. So use that power, enable it, take them to politicians. Politicians will listen to us when they don't listen to us. So that's some of the P's. I think I could give more, but I think the second thing we're asked, as well as reflections, is what to do and what will we do? So I can tell you, first of all, I will use this brief. I will share it. We will share it with students. We have thousands of students. But also I think we need to intentionally shape the implementation research. Yes, we have evidence to say, do this. Yes, we have some models, but we really need to look at how we adapt, do this. We need to look at how we cost it, how we make the investment case. And very importantly, we need to be able to measure it in routine systems, otherwise we won't know what we're doing. So we commit ourselves from our team, both the Nest 360 team that's implementing with 4 African governments, how do we operationalize at-risk follow-up and empower parents and measure, and also within the London School, how can we enable leadership in research that really helps to take us into practice. So thank you, my friends. You have power and this brief is power. So let's use it together.
Thank you, Joy. Thank you for those very practical P's, just to throw in another P in there. So I'd like to, let's see if we can action Joy's call to action. Maybe everyone in the chat, maybe we can just take a quick second about how you intend on using your brief. So can we just take a quick second from around the world and let us know what ideas you have about what you want to do with the brief? And we'd love to read some of those after we hear a couple more reflections. So just take a quick second, everybody, and share, what are you going to do with the brief? All right, and speaking of investment case, Allison, over to you from the Global Financing Facility. We'd love to hear your perspective and reflections on this issue.
Thanks very much, Shakufa, and I add my congratulations on this really important thematic brief on nurturing care. Hearing all of the case studies and stories described today and reading the brief and learning what's really required to provide, really true newborn and family-centered care, it made me reflect on the evolution of care of mothers and newborns. And, if you look at a system complexity lens, I think there is a pattern of path dependency inherent in these discussions, and an evidence, as we've heard, of a real maturation. We started with our Almirata, and then moved to selective primary healthcare with our GOBI FFF frameworks. We developed evidence-based algorithms for clinical care. We had our IMNCI, we had our checklists, our tools, all really, really important to provide the, evidence-based clinical recommended care. But I think somewhere along the way, we lost sight of what being patient-centered really means. And we've learned over the last decade of the importance of respectful maternity care, and this guidance, fills another piece of that puzzle, recognizing that we're no longer considering these interventions as icing on the cake or something that you do once you've got high coverage of basic interventions. Rather, this care is integral and needs to be happening from the beginning. As you've alluded to, the Global Financing Facility supports governments across 36 low and middle income countries to examine and implement health system reforms that can act catalytically to improve RMNCHN outcomes, which includes in many of our investment cases, nurturing care and early child development programs. But listening this morning, it made me think about a number of important takeaways around the health system requirements to enable nurturing care. And I think, as others have already said, one priority is in the health workforce, and we need to go beyond more training to really finding the levers that can support health workers to have the time and the space and the motivation to provide respectful and nurturing care from birth. We know from experience that time spent listening and counselling with families is often the first activity that gets dropped when health workers are under pressure. And I think also that in many settings, the starting point for ensuring nurturing care is prioritised is to ensure that the health workers themselves are respected and given a voice and decision space to arrange with parents, with families, how that care is delivered. Trust begets trust, and mutual respect between health providers and families requires the therapeutic alliance, as described by Artie earlier, perhaps with the addition of a triangle of the health planners as well. So on behalf of colleagues of GFF, we look forward to sharing and promoting this thematic brief in everywhere we go, and inclusion of nurturing care in our work with governments. Thank you very much again. It's great.
Thank you, Alison, for the encouragement, the encouraging news about what GFF is doing to support this. And on time, Nina, over to you. I've seen a few excited people who are excited to hear you speak, so we'd love to hear your reflections. And I just want to note the really great commitments we're seeing streaming through the chat. So please continue sharing what you intend on doing with the brief, and maybe organizing colleagues can drop the link in there one more time for everyone to have it. Over to you, Nina.
Thank you, Shakuve, and hello everyone, all the champions who are on this call today. 328 I see just now. Today's event is taking me down memory lane to the year 2019, when WHO, UNICEF, USAID, every preemie scale, and the project that I was in at that point, Maternal and Child Survival Program, we worked on together to develop an evidence synthesis document that summarized the evidence and best practices. And many of the champions here, I've recognized having talked with them. This report actually included case studies, and we had included case studies from 7 low, middle, and high-income countries. And what a lot of wealth of knowledge I gained actually talking to all of the people who have been here. I can see Suki smiling, and Bjorn, I don't know whether you remember me, Arti, Natalie, everyone. What we learned, and there were many, many of them, what we learned from talking with these champions was that health providers of low middle income countries are familiar with nurturing care interventions. They understand the rationale behind it. Nevertheless, what they expressed was what everyone spoke about today, this lack of supporting enabling environments that challenge their ability to implement these practices, often forcing them to put nurturing care in the back burner to prioritize life-saving care. Yet, what we heard today, there are champions who've been doing all of these in their small world, and we heard from the 4 of them today. Despite these challenges and substantial differences in resources among them, we heard how they found creative ways of weaving nurturing care practices, not only in their own facilities, but also championed to take it to scale. And that's so inspiring. That gives us hope, I think. That gives us hope that we can take one step at a time, make a small change, and keep moving forward. I'm currently on the USAID's Momentum Country and Global Leadership Project, which is a 5-year project with a presence in over 18 countries. We work with governments, local partners at the national and subnational levels. We are very excited for the launch of this thematic brief and would like to take the opportunity today to express our support to providing nurturing care for every newborn. We are currently in conversations with ministries of health and USAID missions in Nigeria, Kenya, Ghana, Nepal, Indonesia, and we are hoping to work alongside with them to adapt and adopt the WHO standards, especially the ones on small sick newborn care, and which actually, as we know, puts nurturing care front and center. We hope to actually learn from ministries of health, the country stakeholders, the champions that are there, so that we are able to work with them on a contextualized, comprehensive, nurturing, high quality nurturing care model of care. The learning that will be generated will inform scale. That's what we aim for, but we will also learn from them, all of us. Thank you for the opportunity to be here today, to have this forum, to exchange ideas and knowledge, and to share our commitment to nurturing care for every newborn. Let us together ensure our next generations not only survive, but also thrive and make the world a better place to live in. Thank you.
Thank you, Nina. That was brilliant. Thank you so much. And just as we're closing, and I'm going to hand it off now to Bernadette to close us, I just want to highlight some examples of commitments. Chiku from Tanzania said there's a network of ECD journalists who they're going to take this up. Abosidi from Nigeria said it should be an integral part of their country every newborn action plan. Marilu says she's going to share it with health groups, implementers, and policymakers in Peru. And just to close it off with Bjorn's words, skin to skin is the enabling environment. So with that, thanks everybody, and over to you, Bernadette, to take us to the end.
Thank you very much, Shikufe. Thank you very much, colleagues who share these reflections, for kind of, again, putting different perspectives, emphasizing key points of what we need to look at. It looks like the brief provides us an entry point to a journey, to conversations that we need to continue, and we need to learn from each other in order to motivate, to improve, and to catalyze the actions that we would like to see. We are just on half the hour. We are meant to close, but we have 2 speakers that we would not want to miss. So I ask for your indulgence and like to move quickly to introduce to you Dr. Tedbab Bedegafi Hela Gabriel from UNICEF, who is a senior advisor MNEH there, and Dr. Anshu Banerjee, who is the director in the department where I work. Tedbab, if you could put on your camera and share in a short time your reflections, and then Anshu will follow and close this session.
Thank you, Bernadette. Hello, colleagues. I don't know what I have to say, after this really remarkable and very informative presentation we just heard. Which took us, as Nina said, to memory lane, where, the global maternal newborn health group starts working to improve newborn health, starting, early 2000, starting from developing the policy framework and focusing, just struggling to scale up essential newborn care. And after 2 decades, here we are talking about nurturing framework that will help us ensure that newborns not only survive, but also thrive and achieve their full potential, which is their right. So we have, heard from our esteemed panelists in the country experiences that policies, programs, financing efforts that have demonstrated from small-scale learning projects that influence to national scale of implementing evidence-based interventions that ensure both survival and also ensure newborns are thrive. My, primary reflection, listening all this presentation and also reflections from partners is that we need a very strong primary health care. We are not talking about only, tertiary level care, but also, to the level, household, community, and empowering and engaging parents. That primary strengthened primary health care should be able to develop and deliver quality of care, both for mothers and the newborns, where they are and where they need it. And through this infant and family-centered developmental care, we are empowering parents. We are having a huge paradigm shift where we look at clients as a source of infection to NICU, or just a recipient of care that we provide to an integral part of care provision services. So listening all to this, my challenge to my colleagues who are in this panel, who are now remain to the last part is, what one important message that you can take forward and apply it in your day-to-day work, whether it is a clinical service or whether it is engaging in formulating policy, developing program, or developing or teaching students and developing the next generation of healthcare providers. What one thing can you take? I'm sure, the presentations, the country experiences, and also the partners and reflections have been able to provide you with really critical information that you take. As Joy mentioned, evidence is power, and I think what we have in this note is that we have this evidence that distilled and that would be useful for actual formulating policy and informing programming. And lastly, this framework also helps us support and inform our policy makers who are key, because we have seen from this country presentation that political will, commitment is key if we want to see that this paradigm shift takes into practice and changes the way services are provided. And again, I want to reiterate also what Nina said. We have the opportune time and also the momentum that have been gathered for the last 2 decades to ensure that the newborns we are caring now are not only surviving, but are thriving and achieve their full potential. Thank you again. Over to you, Bernadette.
Thank you. Over to you.
Thank you very much, Bernadette. And I think it's been a fascinating webinar. It's really highlighted what nurturing care is about, and also what the nurturing care framework actually states. If we change the beginning of the story, we change the whole story. And this really takes a life course approach into this. What we heard today really is, I think we still need to make the paradigm shift in many settings from a provider-centric care model to a family-centered care model that involves parents. And this needs to become a reality still in many places. We've heard that healthcare workers often have been difficult to be convinced, but often that once they see the benefits of the family-centered model, that they're really converted. And I think the survey that was conducted amongst parents also reflected in how many places still this is not a reality, that mothers and fathers and siblings are involved. And this is a role that we need to play to make sure this happens. I think we all want that all newborns must receive nurturing care, not only to survive, but also to thrive. And that every newborn, whether small, whether healthy or small or sick, that everyone has the same right to the same start at the beginning of life, and that we should be able to provide the best possible care from the beginning. So I think we have shown actually that besides the fact that this mindset is needed, we have shown that this is possible. And we have shown this for immediate KMC, and also for scaling up KMC, and that there are a number of countries that have really been able to scale up KMC quickly from low figures like 20% to much higher figures up to almost 80%. And key to that actually is what many people have also highlighted, is to have an enabling environment to really support the family to be there, to provide that care for their newborn together with the health workforce. These interventions should really be part of universal health coverage, and I think we have some advocacy to do that, to make sure that these are included within universal healthcare packages and that they are delivered through a strong PHC system. As WHO, we're committed to be a strong advocate for this and to be a technical partner. We will work with governments and the international community to translate the evidence that has been presented also into practice. We have recently published, of course, the standards of care for maternal and newborn health, but also the standards for small and sick newborn care. We have launched recently the human resource strategies for small and sick newborn care, and are soon going to come up with an essential newborn care course. I want to thank everyone who participated, and maybe we can have a final slide, Tala, that really shows where you can find a lot of this information. We have the sites of our different partners that also have a lot of materials available. And this will of course be shared with all the participants in order for you to be able to see where you can find this material. And we do this jointly with the Network for Quality of Care, with the Child Health Task Force, with ECDAN, and of course as part of Nurturing Care. Thank you very much.
Colleagues, this brings us to the end of our conversation today. Thank you all for your active participation, first and foremost, all the presenters, but as participants through the chat, we hope you have had opportunity to share thoughts, get to know who was with you on this conversation, and that in the future we will create other opportunities, find them to continue the dialogue and to continue actually working together to make happen what I think all of us are passionate about. So with that, we have to take leave from each other. As Tala said, the recording will be shared. The details of where you can find the brief are here on the screen. We wish you happy reading, and we look forward to meeting you on the next occasion again. Bye-bye.
Bye.